primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care is the opportunity for me personally to practice medicine the way I thought it was going to be when I decades ago decided I want to be a doctor. And so this has been the culmination of all the things that are good about medicine that we could put together. And I think that's what's made me most excited about direct primary care.
Direct primary care to me is really freedom. It's freedom to take care of my patients the way that I want to take care of them. Freedom for me to also be a person and for me to be the wife and mom that I want to be as well.
I'm Dr. Michelle Little.
And I'm Dr. Kayla Juba, and we're the co-founders of Foundation Direct Family Care here in Dalton, Georgia.
And this is our DPC story.
Dr. Kayla Juba is a graduate of the Georgia campus of the Philadelphia College of Osteopathic Medicine and completed her residency at Floyd Family Medicine in Rome, Georgia in 2019. Now residing in Tunnel Hill, Georgia with her husband and 3 children, she finds joy in her family, her practice, decorating cookies, cooking, and gardening. Dr. Juba chose family medicine in part because of the opportunity to truly get to know her patients, and this unique practice setting allows her the time necessary with patients to do. Family medicine allows her to care for both chronic and acute needs for the whole family. She has a special interest in women's health, menopause management, mental health, and in-office procedures. Dr. Juba is excited to provide comprehensive and personalized care to her community. Dr. Michelle Little is an honors graduate from Edward Via College of Osteopathic Medicine in Spartanburg, South Carolina, class of 2016. She later completed her residency at Floyd Family Medicine in Rome, Georgia as well, serving as chief resident in 2019. After 2 years practicing in Calhoun, Georgia, she co-founded Dalton's first direct primary care practice. Outside of her medical endeavors, she finds joy in reading, travel, and non-running exercises. While she appreciates all aspects of primary care, Dr. Little has a keen interest in diabetes management, weight management, and holistic wellness. Fluent in Spanish, she aspires to introduce a new healthcare approach to Dalton and to Northwest Georgia. Dr. Little resides in Rocky Face, Georgia with her husband, son, and daughter. Welcome to the podcast, guys.
Thanks for having us.
I met Dr. Juba and Dr. Little at maybe a year and a half ago, if not over that, at Dr. Sharon George's retreat in Napa. And it was such a treat to talk with you guys, hear about your practice. And so I'm so excited for the audience to hear your story as well.
Thank you so much. We're excited to be here.
So you guys are in the northwest portion of Georgia, and just looking on the map, you guys are closer to Chattanooga, Tennessee than you are to Atlanta. And just talking a little bit before this interview, you guys are about an hour out of Atlanta. So just to give people a geographic bearings on where your practice is. So I want to start because you guys are you come into the room and it's so filled with excitement and passion and love for your practice and just the relationship that you guys have with each other. And I love that you guys have built this bond over years. You went to residency together, and every one of us has been to residency, and it is hard as hell some days. And you really learn who are your family members from different misters when you are doing your Q whatevers and you're dead and you still have to see patients and still have to put on a hat to be decent with other people. So tell us about your guys' experience in residency and how did you guys come to develop this relationship where you are not only so close, but able to support each other professionally in the entrepreneurship world of direct primary care?
So residency, as you mentioned, is a trauma bonding experience. I think Floyd was no different. One of the things I think that made our experience so good and set us up for being able to start a practice like this was realistically having an unopposed residency. So that helped us a lot. So all of our attendings in any rotation treated us like we were a resident of their specialty. So when we were doing ER, they treated you like you're an ER doc. When you were on your OB rotation, they expected Q4 notes. They didn't care if you had to do other admits. And so I think they just well prepared us in each of the aspects of what truly family medicine becomes, which is a little bit of everything. And so I think our training was just very strong in primary care and family medicine. It did not focus solely on outpatient family medicine. We were very inpatient heavy, which I did not like. I'll let you talk to Dr. Juba about what she did like it. But again, I always give respect and kudos to the fact that our inpatient heavy residency really makes us what we consider strong outpatient docs, because you got to know what sick looks like, and that a lot in the hospital. So I think our program was strong. We had a lot of experience in sort of different aspects of primary care. And I think even our graduating classes have been very diverse. And some do ER medicine, some do urgent care, some do traditional outpatient, some are hospitalists. And so the fact that all of us got the same training and could choose different jobs or go on to a fellowship really speaks to the quality of the program.
Yeah, so we really were in the trenches together in residency. We really dove into the trenches together and being business owners as well. So we having hard conversations and doing hard stuff when you have very little sleep was not new. We also just happened to really our lives outside of medicine lined up too. We went to go work for the same health system outside of residency, different settings. I was a hospitalist and Michelle worked in the outpatient setting about 30 minutes south of us. And we had babies about the same time, and going out with babies is chaotic. So we would go to each other's houses and let them just be feral at each other's houses. So we would commiserate about, this is the stuff that we really don't like, and this is what we're frustrated with. And even the different settings, they were a bunch of the same things. Pandemic hit what was it, 6 months into our first real people out of residency jobs. And so we didn't really know what was going to happen. It was maybe we're going to die. I don't know. And we were both pregnant. And so we were like, dang, if we're going to die, this sucks.
Probably don't want to do it in this way.
Yeah. Let's just
spend some time with our
happy
and our kids.
Yeah. So we were like, I think, are we going to quit our jobs? We're doing it. I guess we're doing it. I don't think it was a really unique setting, being in the pandemic and faced with the reality of, dang, if this is what the rest of my life looks like, whether that's for 6 months till COVID snatches me up or 30 years, I want that to look different than what it looks like now.
Super Titanic material, guys. Are we going to do this, or are we going to do it our way till the end, man? So I really think that it resonates with a lot of people, especially people who have opened around the same time you guys did, because that pandemic really changed the way many people looked out on life. And so I love that your guys' outlook on life and your job manifested in your direct primary care. And I think it's really interesting too, because you guys had worked with each other and you knew how you were as people, how you were as doctors prior to opening DPC. I was just on a call recently where people, maybe 3 to 5+ years in practice, are talking about how do we hire new physicians? How do we look for new physicians? And this has come up where people have hired and the partner or the person that they were working with under their DPC just didn't work out for one reason or another. So I think you guys are coming from a very different place, and that wasn't questionable. You already knew how each other worked. How did the talk then go from this epic Titanic, man, we're doing it, or we're going to die. This is not cool to stay in our job in the current form that it's in. How did it transition to opening a direct primary care practice in particular versus doing another job under the insurance-driven world?
So I think we were, first of all, lucky in the sense that in residency, we were exposed to direct primary care. So we had a resident that was a couple of years ahead of us that started his own direct primary care in Alabama. So this concept was already in the back of our mind. I remember when he was talking, it was oh, I'm not sure if I want my patients to have my cell phone number. And I'm not sure, I don't think I could ever do that. But then,
and we owe the government too much money to start our own practice right out. He was telling us it's great, it's going to be awesome, and then we promptly went to work for for a major corporate healthcare system. I think so. The risk and at the time felt like safe enough, and so I think people a lot of times talk about direct primary care. Starting your own business is a risk. It's a challenge. There's a lot of things, but I think the way we did it helped us mentally deal with the risks as best we could. So, for example, we're in the middle of the pandemic. During that time, our student loans were on pause, right? So, the whole explanation that I said in residency, we're like, I got to pay back all these student loans. There's no way I can take a job where I'm responsible for generating everything and hopefully it works and I can pay back. So, the pause really gave us a little bit of motivation because we're like, if we are bad at this, we are not bad at this and having to pay back on our student loans. There's a pause. It's not gaining interest. This feels like a good time in this scenario. And then the second piece being worst case scenario. So you always talk about that. So I think we talked about that. And I said, hey, worst case scenario, if we suck at business, if we can't do this, we'll just get jobs. And so I think that really calmed both our spirits. We're like, it's not like we are undoctored if we can't do business. So we're still doctors. We still have our degrees. We still have our training. We'll just get a job. And then the third thing I think that really helped us was doing it together. So a lot of people feel that sort of intense pressure by being by themselves. And I don't think we had that. I remember talking with my husband and saying, I feel like this is going to work because it's two of us. So we're splitting the risk for everything. So any sort of financial investment we put, it was 50-50. So it was less than other people may have had to put down. And then I think I remember specifically Kayla having to talk me back into it. Maybe this is a bad idea. I don't know if we had a margarita that night at your house and when we decided we're going to quit our jobs, but maybe we should have. And so I think each one of us went back and forth at different times. We're like, are we doing the right thing? We plan to start in like a year. We bumped it up to 6 months. I think from
like for like marriages, they're like, you just can't fall out of love at the same time.
Yes.
So we just can't want to quit at the same time.
Yeah.
Which has held true.
There's always one of us like, what are we doing? The other one's, we could do this. And then it flip-flops for whoever's the one on the we got it boat.
Yeah.
I love it. I want to go into more about how you guys like did the execution of opening, how, you two didn't fall out of love with this idea of DPC at the same time going forward and really not only deciding, but putting the financial investment behind it. But I want to just turn to Dalton, Georgia, because we talked about geographically where it's at, but can you tell us about your community? Because both of you are speaking fluently or proficient in Spanish. And so I'm assuming that there's a large Spanish speaking population in Dalton.
Yeah, so it's about 60% Hispanic. We're a town of, I think there's about 100,000 in the county. So not rural, but not hugely urban either. And there's a lot of small businesses, I think even more so than the average communities. There's a pretty big uninsured population or underinsured population.
Yeah, that was part of the reason also on our pros and cons list that we're like, this could probably work. Looking at we reside in the carpet/flooring capital of the world. And essentially any floor that you step on, that's not dirt. Some part of it probably came from Dalton, Georgia. We've got a large community of working class people, and a lot of them work for the carpet mills in some scenario. And the carpet industry has great insurance options for its employees. A lot of times when you start thinking about extended family, adding a spouse, adding children, those sorts of things were limiting because of the cost that it would take out of people's paychecks. And so a lot of times they were opting to just cover themselves, but not their family. So I think we saw a gap there for extended families. Sometimes in the carpet industry, not everybody was opting into it because we take care of a lot of families of carpet mill workers, but not necessarily the ones who are actually the employees. And then additionally, Kayla already mentioned the small business sort of mecca that is here. There's a ton of just small businesses in the town. And when we started this practice, we thought we will be girl power and get insurance for ourselves. We will carry our families on our backs. And so we looked it up and Googled it, and there's going to be $2,000 per family for us to, as a business, insure ourselves. So we promptly jumped on our husband's insurance. So we felt as a small business, we couldn't even offer insurance for the two of us. It was just two employees and our husbands and children. We couldn't do it financially where we were when we were starting. And so seeing that for us as a challenge, and we obviously weren't going to quit because we didn't have benefits. This was what we had. But there are employees who are like, I got to have benefits. Small businesses were losing employees that were great because they didn't have a benefits package that could compete with larger companies. So I think one of the things we focus on a lot is small businesses and recruitment and retention.
It's awesome. And I really appreciate you guys sharing that, because every community is different and every community's makeup of who's in the community, who has insurance but doesn't have access to healthcare, it all differs. So let me ask you there about now the medical options that are around Dalton, because even for those people who have an employer, but they choose not to take the health insurance policy, are there other centers, like, for example, the place that you guys used to work at, it's half an hour away. What are the options for care in addition to your practice?
Yeah, so there's one major healthcare system in Dalton, and pretty much every specialist office is linked to that healthcare system. There are a couple of exceptions of privately owned health offices, but for the most part, they're all linked to that one major healthcare system. So we were the first direct primary care. There actually are a couple more direct primary cares in Dalton now, which is
good.
Yeah, great. But yeah, everything's big healthcare system feel.
Yes. And so again, there's not a lack either. So a lot of times when you think of a small population like 100,000, you're like, whoa, we should be able to qualify for some rural medicine. But there's a lot of doctors here. And so, I don't think that there's a void in Dalton of healthcare options. But when you still looked at the numbers, there were still a lot of people who are not choosing to carry insurance for one reason or another. And so we felt, hey, we can meet a need here, whether that is a fully employed, works 40 hours a week and has the disposable income to afford our membership, or we have the person who may be new to the country and maybe doesn't have any sort of access right now to healthcare options that aren't in an emergency setting. And our goal was to meet the need where we found it.
And clearly, like, you guys are continuing to fit your community's needs, because you guys have changed locations. We'll continue to talk about your journey, and then the fact that there's more direct primary cares that have opened after you guys, there is not a lack of need for personalized, accessible, affordable primary care. So
Absolutely.
if anyone is listening and saying, oh, but there's already so many DPCs in my town, I just like to point out here what Dr. Nitin Gupta said. If there's 4 corners in a city and they all have a Starbucks, none of the Starbucks will close. And yes, that changed a little bit during the pandemic, but in general, you get what I'm saying. And so everybody, you guys are celebrated by your patients for being you. And that's what your patients are looking for. And they're looking for the relationship with you, and they continue to be your members. So with that, just now going back to the execution and deployment of this thought, this dream, this thing that has become a reality, opening Foundation Direct Family Care. Michelle, you mentioned how you had a 50-50 investment in it, but how did you guys do all of the things legally? What's your contract set up? Are you guys an LLC? How did you guys form your direct primary care?
So as a hospitalist, it's 7 on, 7 off. So she was 100% employed that 7 on, and then had a little bit more free time than I did on her 7 off. And yeah, Kayla was the front loaded person in terms of like boots on the ground, doing stuff like setting up accounts, all the passwords stuff. Now, even everything now is like Kayla Juba, like all of it, which is fine
You
because
make it more generic.
no, we didn't have it at the time because she was that person getting all of this stuff started. My investment at the beginning was mostly financial in the sense of like I'm still working Monday through Friday and I was phasing out. So my job, the hospital actually let me go part-time, which I was grateful for. And so I phased out of my job there, but I still had obligations, and contractually, like I could not start seeing patients until I met my agreed time before I would start. And so there were some things on my end that sort of slowed me down. But Kayla, I don't know, she was like, she would text me random stuff like, I just need your social security number and stuff. And I'm like, okay, fine.
Yeah, sorry.
Go.
No, our relationship is, there's a lot of back and forth. Okay, I have 80% of me to give right now. And I know that that's not going to be the same like next week, next month. And we know that there's going to be ebbs and flows of like when we can give our best and more time. I was a little bit more boots on the ground in the beginning because of just the differences in our schedule. But so we started out as an S Corp and we actually accelerated our timeline. I think I'm trying to think of why that really was, but I think it was mostly because I was discharging patients from the hospital and they were asking like, "Oh, can I see you in the real world?" And it was like not yet, but keep an eye out. But I was like, why can't we really? I feel like we're missing out on these opportunities. So we started out without a physical location. So we were doing like parking lot medicine. I got accosted by a turkey at somebody's house, had to text them, "I need you to come get your turkey." Like,
Yeah. And then, hey, I'm going out of town this weekend, but my patient just got discharged from the hospital with this massive neck abscess. If you don't mind just changing the dressing for me. I was like, no big deal. Hood of his car, Chuck, sterile gloves, pull off this bandage. It was crazy, but also really fun in
Yeah.
that.
Yeah.
Like
So
Dr.
we,
Quinn, medicine woman.
yeah.
We were doing it.
People loved it and they had a lot of respect for, I guess, just doing things outside of the norm and doing what it took to get things done. And our first patients are like some of the most loyal. Like
we beat them up
Yeah.
at the beginning for sure. I was like, hey, look, I can get you this blood work for $30, but you will be my third ever stick in the world. So if you would like a professional, it will cost approximately $1,700 for these same labs. If you would like for us to learn together, I can give you the friends and family discount of $30. And the patients let us, one of Kayla's patients, I will never forget, I heard them at the lab and she stuck them. And this was like, I don't know, a few months in, we were maybe 6 months in. And she was like, whoa, you are really getting good at this now. Did not insult her while she was bad at sticking, but just remembered that it didn't go as well. Like they don't teach doctors. I didn't get trained to draw blood. And I would tell patients all the time, I said, look, I'm not a professional. I was taught how to interpret the blood once it gets out of the body, not how to get it out of the body. We still cheat and use butterfly needles. So any phlebotomists out there, don't come for us. We are doing our best. And our patients think we're awesome because we use butterflies for every draw, not just, for the hard ones. So they think they're getting fancier treatment, which they are, of course, they're worth it. And we only charge them $4 for the lab draw. So way cheaper than a $17 phlebotomy charge at the hospital. Yeah,
I love it. What is it? A therapy technique. It's not necessarily a therapy technique, but like the way to deliver news, the whole like, so here's something a little bit problematic. And then we're going to give you amazing value proposition. It's only $30. And then but you could do the $1,700 and it's perfectly sandwiched in there. And I think that's awesome. I think that I as funny as it was, like I'm laughing over here on the other side, hearing you guys talk, hearing you share this about your patients and the learning as you go, specifically with Flebo. It's absolutely a thing that you can do in your practice if you wish to. I just learned really how to be doing PRP, and I am still having the conversations with my patients. When you go in to get your blood drawn, are you pretty easy stick? Do you get squeamish? Do you start shaking your legs when you are getting drawn? Like I did a stick on a person when I was learning PRP stuff, and I was like, oh my gosh, they were like convulsing in the chair when the needle touched them. And I was like, you are not the ideal patient to be learning on. If you're in this place of wanting to offer Flebo, lab draws, etc., PRP, and you're like, but I've never done it, like that's okay. Here's 3 other people who didn't. I got 1 day in medical school, and I don't know about you guys, but I am a horrid patient. Like don't try to stick me with the needle. Like I will like ugly cry and snot comes out my nose because I was like, I know I'm not having someone who is learning
doesn't know what they're doing.
Yeah, no. Yeah, but everyone's not like me, I should say, in terms of the ugly cry and snot. So that said, when you guys were, doing these things, just delivering care as you could, as especially with restrictions as to what businesses could be open, where you could deliver care. I think that this is something very common in practices who've shared on the podcast who opened during the pandemic, that the value proposition was like so apparent to people who huge systems couldn't offer COVID vaccination or testing, but a DPC could. Or who could change this person's wound? The options are you or go to urgent care, and if urgent care is even open. So I think that it's a great example how you guys really took advantage of the lemons that were on the table during the pandemic. So when you guys were doing this, we're making it work, we are doing what we can, and then you transition to your first space. How did that transition happen?
We were looking at a bunch of different rental spaces. And I will say finding a rental space that like works and doesn't need a huge build out was really challenging.
Mhm.
We found a rental space that we had a kind of like a modern food court situation. There's like different restaurants and boutiques, and it's all like open in the middle with a common area. So there was a space for rent that had its own private entrance on the outside of that. So you're not walking through with your stomach bug next to tacos or whatever.
Or being rolled out on a stretcher, God forbid, we have to, don't mind me.
Yeah.
Enjoy
Your food. So we found a space for it there. We did end up with a relatively costly build out. It wasn't huge, but it hurt in the beginning. But 1,200 square feet feels really big when you have 20 patients and 0 employees. So we moved in there, and it quickly started feeling a little bit small, but we were committed. We were in a, what was it, a 3-year lease?
We had a 3-year lease.
Yeah.
And we had talked about, again, part of our business plan was we will rent our location first. And then 5 years in, we will look for our own permanent location. And I remember telling one of my patients who's in real estate, hey, eventually we want to have our own space. And yeah, one day she called me like a year into the practice and was like, hey, you need to go right here to this address and look at it. And I'm like, I'm at the jail. I'll tell you about that. I worked at a jail for a little bit to pay the bills. But anywho, I was like, I can't go. So I called Kayla. I'm like, go to this address. We have to buy it. And she goes in, she thinks it's already sold because there were 12-year-old Boy Scouts who were cleaning out the Boy Scout building. And they were like, I think it's sold. We don't know. So I called back. I'm like, I can't believe we lost this property. It would have been so great. And ultimately, they hadn't sold it. And we were able to put in an offer on it, which was way not in our timeline. We were not anticipating buying that early on, but it's been a great location. And so we, at one point, were paying a mortgage and rent. That wasn't fun. And again, these were things that we learned, like everybody's like, oh, you must be making all the right decisions. I'm like, no, boo. We have done a little bit of everything slightly wrong at the beginning, and then we figure it out. So the course correct has been steady. We will do something wrong the first time, and then, okay, that was not a good idea. So maybe don't buy a building at the same time you sign a 3-year lease. But it was a good opportunity. I don't think we would have gotten this cool space had we not jumped when we did. And then luckily they found someone who wanted our space, and so they let us out of the lease a little bit early. So that was helpful.
That's about the time that we met in person because you guys had just purchased your building.
Yep.
And it was fantastic to hear about the space and how it was used previously before you guys went in there. But I think that here I want to ask for those people who might be wondering, how did this before you got out of your lease, how did having the rent plus the mortgage affect your guys' decisions to stop, especially Michelle, how you're mentioning your work in the jail and then the outpatient clinic? How did you pivot financially to make it work as well as still being able to be human and be yourselves and not completely burn out?
Financially, like we were literally just preparing to pay ourselves. So we're an S Corp. So any distribution we do is equal. We were like, we're about to give ourselves our first distribution. It literally hit our bank account and promptly went straight out into down payment. We were used to being a little bit poor, broke, struggling. That first financial strain for the purchase didn't feel all that different. But then after that, Michelle was still working side gig jail. I was side gig prison for a while as well.
Yeah, we have another. You want to do another episode?
So I found out I was pregnant with my 3rd child, surprise-ish, but like the timing was surprise, right when we were like moving the practice location. So it was a lot of transition all at once. And I think like talking about timing, like the timing of everything we've done has like probably not been ideal. Would not have chosen the timing of things that have happened, but like we've learned to pivot and make it work?
We did not pay so one of our goals was not to go backwards. So our biggest fear or thing that we didn't want to do was, hey, we'll write ourselves a check in this month, and then if something goes wrong, we won't write a check this month, and then we'll back and forth. So we did not pay ourselves for the first 8 months of our practice intentionally, because we wanted to hit our numbers where we were going to get break even, and then also wanted to make sure, even when we did start taking distributions, that we were able to leave a certain amount in the bank. And so the 8 months no paycheck was painful, but it has allowed us, I think, to make decisions like having enough money so that first owner's draw is a down payment for a building. That was huge and would not have been an option if we had been nipping away at our profits right at the beginning. And we didn't know that the building was going to be an option, but it really helped us, I think,
be prepared for the unprepared,
yes.
for what you can't really prepare for.
Right. So it hurt to pay both a mortgage and rent, but honestly, our mortgage was less than our rent. And we were at the volume that we needed to pay both of those. And granted, our salary or what we paid ourselves at the very beginning is different than what we're paying ourselves now. But again, we tried to keep that modest as we grew to make sure that we always had that cushion.
And I don't know if we had talked about this, but it reminds me very much of the entrepreneurship from the profit first aspect, the idea of not going backwards. Profit First is a great book that I tried to listen on audio version, and then I had to start reading it because there's things in there that I couldn't visualize. But the idea that you guys were envisioning this is not an option to go backwards, I think it's really good for people to hear that, because I think it also puts forth you guys were in the abundance mindset and not the
scarcity mindset versus abundance.
Yeah, you guys were not in the scarcity mindset. And that is something that I feel is very easy to go into when we're not MBAs, when we don't know what is going to come in entrepreneurship, when we expect things to be as easy as it was signing a contract and working for an employer.
Right.
It also makes me think of good debt versus bad debt. Because Michelle, when you were talking about how the mortgage was cheaper than your rent, that is absolutely something to look into, because if you are just paying rent because it's a short-term investment, my cousin, who is the top realtor in all of Century 21 for Canada, she was like telling us this. And for me, it's my husband is the person who's, I need to see all the data first before I make the decision. And I'm like, let's do it. And so my husband was like listening to her talk about how, wow, if we're paying $1,290, that's what we were paying for rent, versus if we were to get a mortgage on a building that was like $900, like that's how, and we're renting it to ourselves. That's one of the decisions. We ended up just buying the building outright. Thankfully, we don't have a mortgage right now, but it's like we thought about it, and the math was very different when you think about good debt versus bad debt. So I think it's really awesome that you guys were in that place to be able to evaluate the pros and cons of each rent versus mortgage. When you guys bought this building, and and I mentioned a little bit how the space was used very differently than when you guys prior to you guys buying it. What happened when you guys made the move? Did you guys do a full build out before the moving started, or were you doing moving out while build out was happening at the new space?
So we started build out here before we moved out of the mill, because we were paying rent for that space anyway, so we might as well use it. So we didn't move out until it was like absolutely necessary that we tried to make the move in one weekend. Our building that we're in currently was the old Boy Scouts building. So it was literally just two huge rooms, two big squares. So we're again talking about we don't want to go backwards, or we don't want to overextend ourselves. So we built out the one back big square to be 2 exam rooms, and we had the most aggressively huge lobby ever for the front big square that
for the 2 people that were in the lobby.
So we built out just the back at first, and we moved like in a weekend, and it was like Friday seeing patients at our previous location, Monday seeing patients at the new location. It was a little chaotic, but we actually just finished the build out of the front huge square. Now we have 3 exam rooms, like an actual dedicated office, some more storage. So
like a front desk space, things that we just didn't have, a check-in area. We didn't have that really when we started. And then one of the things that has helped us be successful is knowing what we know and what we're good at, and then putting people, like letting other people know what they're good at and finding those people to help us. Kayla doesn't necessarily have a business background, but her husband helped open a brewery here in Dalton a few years before we were doing our thing. And so they had connections with CPAs and lawyers and things like that. And so we use that as a stepping ground for us, not to recreate the wheel. I think that also really helped, because there's a lot of times that, and I think we tried to bare bones a lot of things. And there was a lot of stuff that we're like, look, we can do this ourselves. But then there were some things where we just need to pay the money to have the expert do this. And so we paid for a CPA from essentially day one with $0. So he was like, okay, not sure why you need my services, but so just because we don't know how to do this stuff. And having somebody like that as a sounding board, having lawyers be able to say, hey, consider this, or when we were looking to hire our first provider employee, looking over contracts and helping us work through that. So I think that's something that's helped us be successful, is utilizing the resources in our community, and not necessarily the big name necessarily in DPC or what have you. We had to explain a lot of times what we were trying to do to people, and they're like, okay, I think I get it. But I think there's a lot of value in having the people in your town, in your community, helping you grow your business versus the biggest bank or the whatever. I think that's really helped us build relationships and grow our practice, but also feel comfortable saying, you need to talk to my money guy or my banker or my this, because this is not my gift from the Lord.
Some of our biggest advocates in the community, and as far as referring us new patients, are like our insurance guy, our CPA, our bank.
Yeah.
So the fact that we use those things locally really has been beneficial for sure.
It takes a village, and you guys, you lean on each other. And I know, Kayla, you were saying that you were about 80% the boots on the ground person in the beginning, but I know it shifts depending on who's available, who's able, who's knowledgeable, all the things. But I think that's really smart. It reminds me a lot of what Dr. Leah Gupta said when she was opening. She wasn't known in her community. She had been at urgent cares and other practices, but not known as like Dr. Gupta's office. And she was DMing people in social media and going to their places of business, restaurants, etc. But even if you don't use that person in particular, you might use them in the future, or you are developing a relationship with them so that they know that you exist. So like you guys have experienced, oh, you need a doctor. Like, I'm a realtor and you're coming to town to Dalton to buy a house, and you need a there's some amazing doctors over at Foundation. So I think that don't discount whenever you talk to someone about your practice. You guys have clearly reaped the benefits of that. So that's amazing. So let me ask here about now the name Foundation Direct Family Care instead of Direct Primary Care. Tell us about the creation of your guys' practice name.
We went through several iterations of
whether to use DPC or direct family care. I think the reason we decided on family was because we wanted everybody to know that we could do pediatrics, adult geriatrics, and primary care sometimes expresses that. But again, we were bringing what we felt was a new idea. So we wanted the most descriptive thing of what services we could provide. And there's several, I'm sure, DPCs that are internal medicine or only. And so we wanted them to know we're both family docs. And that's how we decided on the family part instead of primary. And then we each brought a name to the table for the practice name. And then we asked our family members and they voted on it. And so we were between our two names, which is Foundation Direct Family Care and then Grassroots. And so interestingly enough, the votes were more for a foundation for our practice name. And so we went along with that. And as things were going, we grew that sort of brand and idea. And then when we got ready to buy our building, I was like, hey, why don't we use Grassroots for the name of the LLC, which is going to ultimately be our holding company. And FDFC will pay rent to Grassroots for the building. And so we actually ended up using both names that were like the finalists in what we have today.
I love that. And also super, super amazing gem right there. Your building is owned by a company and you rent to yourself, basically. People have done it like Dr. Kissy Blackwell. We are doing that right now for ourselves. It is a pro tip. We might not have the bazillions of dollars that the top 1% has, but we can still do fancy things like rent to ourselves. So amazing. Now, how about you guys? Also, when we met, you guys were the two of you plus an administrative person, and that person was somebody who wasn't necessarily the best option for you guys going into the future. So can you talk to us about how you came to the place of, okay, we would like to have somebody to help what we're doing at Foundation, but also how did it, how did you guys work through this is not going to work out for the future, and how did you guys pivot and work Foundation Direct Family Care going into the future without this particular person?
Yeah, arriving at the fact that we needed help, I think that was a combination of a lot of things. Working in the traditional system, a lot of times we don't even realize what all is going on behind the scenes. So I'm the one rooming the patient, I'm the one getting the vitals, I'm the one doing the visit, sticking them for labs, sending the referrals, sending the faxes, scanning all the documents. Like, you just don't realize how much goes into a practice, which is, it's fine to do when you have 50 patients. And I admire the people that do it beyond that. Like, my brain was going crazy. So I think when we had like stacks of papers that we were like, oh my God, like we have
Add
to
and
scan
address
this,
it. Mhm.
we have to fax it. Like, I could just, we're both very type A, which I think is typical among people who are doctors. And I could feel things like, oh God, this is going to start slipping through the cracks if we don't
Mhm.
get some help. So that was the, like, I can't compromise quality because my brain can't do 1,000 things at once.
And that's been, I think, the push every time. So our goal every time is we want patient number 500 to feel the same as patient number 1 did. And that's fine and good when you have 20 each because you can do all the things. But when we're up to, each of us has about 250 patients right now, we can't get things done as quickly if we're also seeing the patients and trying to do the referrals and sending the orders and things like that. And so our goal was for patients never to feel like, back when I started, my $80 brought me this level of care and now it's slipping. And so that has been at the forefront of every hiring decision, every growth decision we have made. Is the minute it gets uncomfortable to the point where we're not doing it the same way in terms of the care that we're giving, or it's not the same feel, then we got to do something different. And we hilariously thought we were going to be a ginormous DPC practice. And then we realized that neither one of our spirits are ginormous DPC practitioners. So we would just keep decreasing the number of patients that we were going to accept. Like, we will each have 500 patients and our panel will be full at 1,000. And then we're like, all right, when we got to 100 each, we can't do this. So we're like, okay, can the community still support a DPC with 1,000 patients? Absolutely. Can we still give the same care to patient number 1 and patient number 500 on our panel if we keep at this rate? No. And so that sort of is probably a transition to another topic for you, but was how we decided when it was time to hire an employee and or a PA or another provider. And yes, we every time we hired or fired or transitioned, it has always been at a point of what sort of quality do we want for our patients, the vibe that we want to still be there for FDFC and for the community that supports FDFC. Least favorite thing about owning my own business is employee transitions.
I think we're so much less hesitant to make employee transitions when necessary, though, than we were. That was like a huge topic of focus when we were in Napa, was like,
We were crying about it.
yeah, like we have this employee who we love as a person, but it's just,
Stressing
it's
us out.
not working out. We're having to micromanage and redirect every step of the way. Like, we're really busy and this is not why we hired you.
And we knew early on, I think, but it took us a total of 6 months to actually do it. And that hindsight, when we look back at it, that hurt us financially in a way that it didn't need to. It didn't set us back in the sense of we couldn't do other things, but I think that also resonated with us, which is because we can't make our practice suffer just because we don't want to have hard discussions. And so now we just rock, paper, scissors, whose turn it is to let somebody go if we have to. I'm not kidding.
We're not terrible bosses. Like, we're great to work.
The truth is, we do it, we get it wrong every time the first time, but we get it right every time the second time. So, note to anybody out there, if you are our first person in a new role, you probably won't make it. I'm sorry. I don't know how we do it wrong every
So
time.
I think it's also there's an evolution of how to be bosses too. So we have come to realize that there has to be like really clear expectations spelled out. And when there's a change in those expectations, you got to really communicate that. We had never been bosses before.
We didn't make job descriptions. We're like, this is what we need you to do.
Yeah.
So then when they weren't doing things, we're like, probably our fault that we didn't tell them what we wanted them to do. Like we did, but we didn't write it down. We weren't specific. And we've gotten better in that.
Yeah.
And just going along with, as you continue to be entrepreneurs, you're going to experience different things. And this is not easy. It's a lot better than fee for service in so many ways. The pros way outweigh the cons, and probably your opinion and mine. But it's not simple, especially if you're opening a DPC from the get-go. Now, yes, there are people joining onto DPCs and practicing with a DPC that's open, and that the entrepreneurship journey might be different. But I do love that you guys have I love the rock, paper, scissors thing, but in general, like that you have come to this point where it's not even the third time that you try, it's the second time. And then in the future, it's going to be that first time. You're going to be on point. And let me ask here though, when Michelle, how you mentioned this like place of feeling uncomfortable, questioning, is patient one getting the same care as the last patient that you just enrolled? How do you guys come to the table to have these discussions? Is it because one of you like has this conversation going on in their head, or is it that you guys have every couple weeks, we're going to sit down and just reevaluate certain aspects of our practice?
We should probably be more organized in the way that we reevaluate things, but it's honestly kind of spur of the moment. One of us will have a little mini breakdown about, I can't do this. And they're like, oh, I was feeling that too. Like we should probably do something about that. So it was like little mini crises that were not individually unique that led to a change. Michelle and I are informal in a lot of ways. Like we're also friends. When we have a breakdown, it's not a secret. Like,
Yeah.
Well,
Yes,
and I'm sure you can call each other out too. It's not even that one has to say to the other, it's okay, something is going wrong because the mood is totally different, or like the way that you're answering the phone, or like you're using all caps in the text, like all the things, like I'm sure you guys read each other too.
Yeah. And I think, again, our growth pattern and desire has always been to grow into the need, because one of our biggest fears was like going too hard and then not making it work. And so it's evidence in every little thing we've done. We only did half of a build out in the beginning because we're like, look, we don't need 15 rooms. We can only see one patient per time. It's fine. We each have our own designated room. It's personalized and designed for each of us. So it's just our room. And I think our goal was not to hire a huge staff and then not have the patients to support it. And so same sort of things with any sort of financial growth, which means hiring a new employee. We've always wanted to say, can this role sustain itself? So do we have enough patients that having finally a front desk, we just turned our phones off of forward to voicemail. It was very stressful for us. Neither one of us wanted to do it. Because we're like, what if we have to go backwards? What if we have to start answering the phone and then it doesn't work out and then we have to shut them back down? And so I think every time we wrestle with a decision that is going to have some financial implications, it's always, what are we missing or losing out by not making this transition? Or how are we like struggling with stacks of paper that are unorganized? Or if a patient needs something and we can't, let's say a patient needs a record from us and we have it here, but now it's not scanned in for whatever reason. There were things that gave us anxiety. And then we're like, hey, we got to have a virtual assistant to help us with this. And then we transitioned from a virtual to in person. And so it's always been, we can't do it by ourselves in this capacity anymore. And then when we got a third employee, we're like, okay, we can't do it with just 3 anymore. Or looking forward to, we're hiring a PA. What do we need to have in place, because our singular MA can't take care of 3 providers in this capacity and also be office manager / front desk / answer the phone. Like she can't do all those roles either. So I think historically it's been, can the patient volume support it, which as our growth improves, yes. So we don't always take raises that we would like, but sometimes the raise is very pinky up. Now we have somebody who answers our phone. And we're now getting patients that are just calling in. Like we were missing that population of people sometimes. They would call in, but sometimes they don't leave a message. And then so if they can say, hey, can you tell me about our practice? And we've got somebody answering that phone every time, that's more volume. Kanisha, our front desk, is making her salary every time she answers the phone and helps us get another patient in, or keeps things running super smoothly from an organization standpoint. So and so refers our practice to their kid or their friend or whatever. Those have been things that made like financial sense for us.
So let me ask here, thinking in we're not going to go backwards, we're constantly going to go forwards, as well as you guys are bringing more people into the practice through hiring, through changing job roles, et cetera. How do you guys go forward in terms of, do you document processes that like, wow, this was causing us a lot of anxiety, but now we're going to document it down so that the next time this happens, we don't have to revisit it. It's already written down.
Yeah, so we have started when our first hire was like, yeah, this is what we need help with, a lot of verbal communication, and that didn't translate into a lot of execution. So we started really writing down like job descriptions for each job that is within our practice. And we have an employee handbook now. And those things are evolving documents as well. We share like a Google spreadsheet doc thing where it's like ideas for Kanisha to do, or like ideas for Nancy to do. And like, we'll talk with them and add on responsibilities, along with raises and stuff too, of things that would help us. So like Michelle was saying, like a lot of times our raises they're not money in our pocket, but it's like space in my brain.
Which is a raise,
Yes.
like our chill, like keeping the same quality of life, even though again, our patient panel is larger than it was. So I had a lot more free time when I had 20 patients, but now I have less free time, but I'm gaining some of it back in the sense of organization, or things are just automated. I was thinking about this in the shower because that's where I think the most, but just one of the things I wanted to add to Kanisha's list was, so the things that she does, could she help us? I think there's some fancy app where you can like, each click is like automated. So in case we grow to a second location, like she would then be in charge of training the next front desk person, but then it's already documented. So that is something I think that's in the works as we are like growing outside of this physical location. But for now, staying here, a lot of our processes have been automated. Number one, by force, because our MA, that the first employee that stuck with us, is very technological and you did that 2 times, so we need to make this an automatic. I'm like, just leave me alone. Let me do my stuff this way. No, make a template. So we have been brought into the new age a lot by having youthful employees. I feel young, but apparently not young enough to like technologicalize everything. Yeah, Nancy has done a really good job of just saying, you've done that 5 times, so maybe set up something that you don't have to do it like that anymore. So that has helped a lot, I think.
Yeah.
That's awesome. And let me ask you, just dipping back a little bit into the transition of an employee versus the hiring. When you guys, this first employee that it was like Kayla, you're saying it's more word of mouth, you guys now have job descriptions, but when you guys were talking about that it took 6 months to offboard this person, talk to us about this journey. How did you guys come to a place where it was comfortable with what you were doing? Because you guys had a pretty unique way of approaching like the number of days that this person was working in person versus virtual, versus like in 2 weeks, you're not going to be here. So can you guys share a little bit about how you approached the transition or offboarding of your first employee?
It was a little bit like, yeah.
It was traumatic.
It was not really like, the virtual stuff wasn't really our choice, and it came about in a weird kind of way. We like offered more hours and they said, I think I would rather work virtual. And there was like so much like shock in how the conversation went down. We like blacked out and said yes, which like hindsight, just don't do that. But so after we said yes, Michelle and I were like, what just happened? And like how and why? So after that, we came up with an action plan of, on paper, this is what we need to see from you. This is what needs are not being met that we absolutely need. And in a virtual day, what does that really look like? It does not look like going and running errands, the car wash, and you're on call for us. It's you are going to be sitting down, tippy typing, actually doing work. I hate to. We learned that you can be taken advantage of if you aren't firm. And if you aren't, like, the same way you have to create boundaries with your patients, you have to create boundaries on what you're comfortable with in your workspace and with your employees. And we were not the best at first at creating those boundaries. And it's still a work in progress. But after that action plan, it became pretty clear that those needs were not going to be able to be met. And we wanted to be fair bosses, right? So we said we have been more than fair and giving you multiple chances and this last very clear, very concrete chance to make changes. And I think that's what gave us the peace of mind to really say this is not going to work out, is we were very clear and concrete, and it still was not happening.
And then again, on our first employee, if that makes sense, based on if you've been listening this long, that process took 3 weeks. In and out, 3 weeks. It just wasn't the right fit. We love you. Here's your first paycheck. You don't have to come back. And we have gotten better at it. And I think the first time and how challenging it was and the things that we learned from that experience that we did incorrectly as employers, we were ready for the second time that we had to do it because we had assigned, these are my responsibilities. These are my work hours. So when we're late on our second, third, fourth, and fifth day of work, I'm just like, hey, what's going on? And their thought process was, I thought it was like a window of time. And I'm like, no, 8:00 means 8:00, not between 8 and 8:30. But they were coming from a job where there were multiple MAs. And so you could be a few minutes late because there's 4 of you. Everybody can give and take as they need, but you are the only one. So if I have an 8:00 patient and you don't get here till 8:30, I am now rooming my own patient. And therefore, that paycheck should come to me, right? But we are giving it to you. And so I think having those expectations made the conversation less hard when we had to have it. And then because we talked with this person prior. So thankfully, also having an office manager, we were able to let her do the official 3-week let go. But we did talk with that person and say, hey, these are the things that we're not seeing. Can you work on that? And I just don't think it wasn't clicking. I don't know that it just wasn't the right fit. And I don't think she was overly upset about it. We didn't know. It just wasn't the right fit. And again, sometimes transitioning out of corporate medicine into a DPC sort of vibe is challenging, especially if you're so used to things working in a corporate way. There's just like a lot of nuances in DPC so maybe our second best, right? Number 2, had no experience, and she is awesome. And it's because she didn't have anything to compare it to. So we're like, this is what we want. This is the vibe. Yes, I get it. I'm receiving it, and it's perfect. So
yeah, nobody's ever going to love your practice as much as you do. This is our baby, but you want somebody that's going to be an extension of you. Nancy, our current MA office manager, she wears many hats, but we actually met her doing a business pitch. So we were pitching our practice to a business, and it just so happened that business was closing because the owners were moving. And so she heard and really believed in our mission, and she reached out to us. I think her title said shooting my shot in her email. And she was like, I'm looking for a job. I really loved what you guys are doing. You got to find somebody that's really going to buy into what you're trying to do, or else patients are going to feel that they're not invested.
I totally agree. And I love that you guys weren't discriminatory in terms of oh, you don't have minimum this amount of education or this particular degree or whatever. I think about when I was 16, I'm sure you guys are the same boat. Did I know much about life? Hell no. But was I enthusiastic to learn, and was I a hardworking person? Absolutely. So it's not to say that you've got to hire a 16-year-old, but absolutely think about there's a person who was in your community, who knows the community, who has been in a small business in your community, and who wants to continue being in the community and doing all those things, but wearing your hat. Amazing. So now let me ask you here, in addition to Nancy, and I want to ask about Beth, the PA who's joined recently, who are all of the employees after you two?
So there's Nancy. She was the original, the keeper, second first hire, the keeper first hire. So she's office manager / and then we hired Kanisha. She's more front desk scheduling, the a records kind of manager.
But she has an MA, and we asked too, we're like, hey, do you have a preference? We need both of these roles filled. Is there one that you want to focus on more than the other? She's like, hey, I got the experience with the front desk. I'd like to start there, but we need blood draws. She can do it. So like everybody having being able to wear multiple hats has been really awesome here, but she's been great. And then we had Beth when maternity leave, right?
Yeah, so I worked with Beth. Beth is our new PA. So she's been with us about 2 months now. So I worked with her as a hospitalist. She was a PA on the hospitalist service. So I knew her pre-DPC. She was great. During COVID, the hospital system fired all of the NPs and PAs. So we went from, they were doing our admissions for us. So like our rounding was not interrupted by, hey, ER calling with an admission. So all of a sudden we were being pulled in a million different directions. It was terrible, but it's sidetracked. So I knew Beth and I knew her medicine and I knew like her decision-making processes. We had worked really closely together, so I trusted her. And then it came time for me to take maternity leave for my third baby. And I was like, I can't be gone like 12 weeks, but I would like to be able to be gone a few weeks. So Beth covered my maternity leave. So that was a way for her to dip a toe in and see, is this going to be a good fit?
And it was helpful to me as well, right? So not saying, okay, I went from 200 patient panel to 400 patient panel overnight. And again, because we were transitioning, so Kayla was slowing down, so wasn't scheduling as many, but there were still people that were like expecting to be seen on this week when baby comes. I think that really helped. And it was a gateway to us seeing how Beth worked in a direct primary care setting. And it went really well. She also covered for me when I did a mission trip out of the country. We had both of our patient panels had experience with her texting them back or having a sick visit or things like that. It felt natural and she fit in with our current patients. And so we brought her on not to, and I know a lot of DPCs do this differently, but we asked her to come on so that we could keep, as I said earlier, that the vibe. So she is growing her own patient panel as we speak. And so not so much covering sick visits for mine and Kayla's panel. She will develop her own panel and have her own patients that she follows because we want, again, patient number 1000 to feel that same sort of connection and closeness with their provider that our first few patients do. And so we felt instead of making ourselves see the most patients we possibly could, it would make sense to keep our panel smaller, but add more providers.
Amazing. Now, looking back at your guys' journey into deciding DPC, opening DPC, growing DPC in terms of your space, the number of patients, the number of people who are working with you, do you have any, oh man, talking to Dr. Little before or Dr. Juba before, are there tips that you guys like to share with other people about if you're thinking about opening DPC, let me tell you.
I think there's a lot of overthinking, honestly. Like people like to overthink and plan every little minute step. And I can promise it's never going to go according to whatever plan you lay out on paper. So just do it. And there will have to be pivots and redirects and mistakes, but just doing it and committing to it is the hardest thing. And that's, even in little business decisions we're making day to day, shoot and redirect. You just got to do something.
And I think, again, that has been a benefit of going in with a partner. So I'm not saying that's the right thing for everybody, but for both of our personalities, I think it has really worked out well because there's sometimes that Kayla's, this is a great idea. Let's push forward with this. I believe that it's going to work. And I'm like, oh, and vice versa. And I think that has helped us just do it in the sense of not overthinking it too hard, that you're indecisive. And I speak a lot about this. One time I'm like, am I really about to quit my job? And then I thought, Kayla said, yeah, like she's doing it. I can't just let her quit her job. And then I'm like, psych, gonna stay at mine. And so I think those moments where that panic sets in, if you're by yourself, you can talk yourself out of it for sure, because we have talked ourselves out of various things and the other person, no, ma'am, we are fully committed. And so that has been helpful. Ultimately, I think maybe my biggest piece of advice is similar, but like, you don't need a business degree to start a business, right? Like, it's not harder than med school. Like, it's not harder than residency. Is it a little quirky? Yes. Are there things like, do you sometimes have to plunge your own toilets? Yeah. But you have to do that at your house too, occasionally. So it's fine. Like you didn't just say, I'm never going to buy a house because I might have to repair something or learn how to do this. Like you can learn it. I don't think my plumber went to business school, but if my toilet didn't flush and I needed to call him, yes, ma'am, I'll be out. But it's $125 for me to get out of bed and come see you. And we pay it. No questions asked because we don't want poop coming out of the toilet. That was a really weird, I'm sorry, but I'm just saying there are lots of people who run businesses who didn't get an MBA. If the medicine's there, if your skill there is there, if you care about your patients, I think you can do it. And that has been the thing that, and worst case scenario, if you're that type of person, just get a job. Like you might suck at it, just close it down. No big deal. You don't have to tell anybody, just fade into your other job. So it's fine. Like the worst case scenario for us is not as bad or as steep as for other people and other professions. If this doesn't work, this is the end. If this doesn't work, would it suck to have to go back and work in corporate medicine? Absolutely. But could I pay my bills and eat? Yes. Our worst case scenario is not the same as other people. So yeah.
Thank you so much, Dr. Juba and Dr. Little, for sharing today.
Thanks so much for having us. I feel like DPC famous now. I think you asked us to come on when we were in California. You're like, we should do it. I'm like, girl, we are barely DPC. Like we are not in it enough. I didn't really know if we were going to have enough to talk about today. I was like, I don't know if we're like better seasoned DPCers, but thank you so much for inviting us to share our DPC story.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Marielle Concepcion.